My name is Rachel O'Brien. I'm a clinical research nurse in Edinburgh with the Emergency Medicine Research Group. I am here to talk to you about the early use of CT coronary angiography in patients with acute chest pain and the findings of the rapid CTCA trial. The rapid CTCA trial was run from Edinburgh across the UK, and it was led by Professor Alistair Gray, and we collaborated with Steve Goodacre in Sheffield, Jason Smith in Plymouth, as well as other cardiologists, acute medics and radiologists from across the UK. So I'll just give you a bit of background about the use of CTCA and the evidence in patients with acute chest pain. We're all aware that chest pain is one of the commonest complaints in patients presenting to the emergency department, and routinely these patients are evaluated with urgent diagnostic investigation, so acute MI can be promptly treated. However, there does remain a lack of clarity on optimal diagnostic pathways, which has led to the development of numerous risk scores and the use of numerous functional and anatomical testing options to investigate for underlying coronary artery disease. There have been several trials exploring the role of CTCA in low-risk patients presenting to the emergency department with chest pain that have shown benefits. However, the use of CTCA in patients with acute chest pain with intermediate risk for acute coronary syndrome has not been established, hence the need for the rapid CTCA trial, which set out to establish whether the use of early CTCA improves clinical outcomes in this patient group and subsequent clinical events at one. So all EDs have their version of this chest pain presentation protocol for rapid rule-out of MI, and they may well drive forward further investigations in defensive medicine, but acute coronary syndromes can still be missed. In addition to this, investigations are only useful if you identify the correct investigation for the correct patient group, and not all exclude or diagnose coronary artery disease. The current protocols may well support short-term diagnosis, but we do need to think about the longer term. Given this and the fact that we don't know what investigations are best and that everyone has different approaches, even in the same hospitals, there was a need to look at more functional anatomical testing and whether or not these can provide improved patient outcomes. So, more randomised controlled trials are needed in order to move on the evidence base, hence the rapid CTCA trial. So I'm just going to touch on the rationale behind establishing whether or not the use of CT coronary angiography would be of benefit to this intermediate risk group. So I'll just talk about the previous evidence. Some of you may well have heard of the SCOT-HEART trial. This was a large multi-centre randomised controlled trial in over 4,000 patients with possible angina, looking at CTCA versus standard care. And as you can see here from the data, the CTCA arm in blue, the cumulative incidence of death from coronary heart disease or a non-fatal MI 5 years after these patients had gone on to receive a CTCA in the trial was significantly reduced in the CTCA arm, resulting in CTCA being adopted in this patient population into the NICE guidelines. There was a similar North American trial called PROMISE, which showed very similar findings. Looking at why the data in the SCOT-HEART trial probably changed outcomes, it was seen that the main reason is not all about invasive coronary angiography, as you may well think, as it is in a lot of CT trials. The patients in the CT arm had a higher incidence of invasive coronary angiography and revascularization, but in the SCOT-HEART trial, the use of preventative medication were likely the main reason that these patients in the CT arm had better clinical outcomes, as a proportion of prescribed medication was much higher in the CT. Looking at the evidence from other CTCA trials in acute chest pain, the cumulative data showed no difference in subsequent MI rates, no difference in MACE, a variation in hospital reattendance, but overall no significant difference. There was, however, a reduction in cost and length of stay, but this is largely likely to be due to the fact that these were mainly North American trials, so not the same way that we treat patients here in the UK if they're to present with chest pain. So to summarise the trials looking at the role of CT coronary angiography in patients with acute chest pain, the data shown here shows that the CT arms of the trials showed higher rates of invasive coronary angiography, resulting in increased rate of revascularization. There was one small European trial of 600 patients that did show a statistical difference in the primary endpoint shown here on the slide. where they did long-term follow-up. But here the health warning is that the number in this trial was small, so it's pretty marginal data, and it's subjective multiple endpoint, so not practice changing. And the aim of this trial, the CATCH trial, was to investigate long-term clinical impact of CTCA guided treatment strategy in patients with recent onset acute chest pain compared to standard care. The CTCA appears to improve clinical outcomes in patients with recent acute onset chest pain and normal ECGs and normal troponin values compared to standard care with the addition of a functional test. So in summary, for the evidence of CT coronary angiography in stable and acute chest pain, the use of CT increases invasive coronary angiography and revascularization, and in stable chest pain increases use of secondary preventative medication and improve outcomes. But in acute chest pain, there is no definitive for changing outcomes. Again, the health warning is that the majority of this data comes from North American hospitalizations, and this is likely that a lot of UK clinicians would not investigate this patient population for coronary artery disease anyway. And we don't really have any information at all for intermediate or higher risk patients. So since the rapid CTCA trial was funded in 2014, there have been updated European Cardiology Society guidelines which recommend the use of CT coronary angiography as a possible additional test after MI has been ruled out, and in those who are intermediate risk where troponin is equivocal or patients with higher risk chest pain factors. But these were implemented with limited evidence. So given the lack of evidence in this patient with intermediate risk for ACS having a CTCA and improving clinical outcomes, we conducted the rapid CTCA trial, starting recruitment in 2015 and finishing in 2000. The rapid CTCA trial was designed as a prospective, randomised, open-blinded, endpoint parallel, group clinical and cost-effectiveness trial of early CT coronary angiography in the management and outcome of intermediate or high-risk patients presenting to the emergency department with suspected or provisionally diagnosed acute coronary syndrome. And we were evaluating the use of early CT coronary angiography and standard care versus standard care alone. And the primary endpoint for the trial was all-cause death, or type 1 MI or type 4 BMI at 1 year. So we spent a lot of time deliberating over the trial population and considering the inclusion and exclusion criteria. And we set it on adults presenting to hospital with suspected or acute coronary syndrome with at least one of the following: a prior history of coronary artery disease, a troponin above the 99th centile, and/or an abnormal ECG. Although we included raised troponin and an abnormal ECG, you will see from the exclusion criteria that we did exclude the higher risk patient population. So the trial ran across 37 UK centres, both with on-site cath lab and those without, across all 4 nations of the UK over a period of 4 years. So this slide here demonstrates the trial population we recruited into the study, and as you can see, we did recruit the patients we set out to recruit, with predominantly recruiting males in their 60s in the more intermediate risk group. 60% of those recruited had elevated troponins at the time of presentation, 60% had an abnormal ECG, and there was a high incidence of cardiovascular risk factors. With regards to the trial intervention, 87% of those randomised to have a CT had it performed. It was performed in just a median time of just over 4 hours from randomisation, and there was a good diagnostic quality in over 90% of them. There was a standard average radiation dose, and there was no major adverse reactions to any of the patients in the trial that had the CT. So this slide here shows the findings in the CT arm of the study and the relationship between the CT abnormalities. The blue bars show those in the CT arm that went on to have invasive coronary angiography, and the orange those that underwent revascularization. And you can see here it demonstrates a clear relationship between the CT findings and the subsequent invasive angiography and revascularization. Looking at our primary endpoint of all-cause death or subsequent MI at 1 year, you will see here that there is absolutely no difference between both arms. So looking at the impact on invasive angiography and revascularization in both arms, CT shown in the red, you will note that there was a reduction in invasive coronary angiography in the CT arm, but no difference in revascularization between both arms, suggesting that CT might have the possibility to reduce invasive angiography where no intervention is required, which might allow the CT to be able to triage those that were actually required to go on to get intervention. Looking at an impact on treatments. If you remember the Scott Heart trial in stable chest pain, the likely mechanism of the improved clinical outcomes in the CT arm was due to the fact that there was an increase in long-term prescription of secondary preventative medication. Given the Kaplan-Meier curve I just showed you in the rapid CTCA primary outcome slide, it will come as no surprise to you that there is no difference in secondary preventative medication or treatment between arms in rapid CTCA. However, there was some important benefits and impact on clinical care. Namely, clinicians felt that the CT results certainly increased their diagnostic certainty, and patients in the CT arm were more satisfied. However, this did come at a slightly higher length of hospital stay in that arm, as well as increased healthcare costs. So just to give you an idea of the data and their discharge diagnosis, this was a group of undifferentiated chest pain patients, and this slide showing the discharge diagnosis demonstrates to you that they were of high risk, with around 40% having a discharge diagnosis of an end-STEMI. Just to put this into context, in the UK, between 15 to 18% of ED attendances worked up for acute coronary syndrome actually had a diagnosis of acute coronary syndrome at discharge. So we definitely recruited the higher patient population. In addition to this, the CT coronary angiography was associated with a reduction in the need for further downstream ischemia testing, underlying its diagnostic utility and associated improved clinician. So in conclusion, for the findings of the rapid CTCA trial, early CTCA in intermediate or high-risk patients presenting to the emergency department with suspected or provisionally diagnosed acute coronary syndrome has no effect on the overall treatment and prevention of acute coronary syndromes or one-year outcomes, and it is associated with a modest increase in length of hospital stay and healthcare costs. So the findings of this trial do not support the use of early CT coronary angiography in the intermediate or high-risk patients with acute chest pain. So just to conclude, the clinical assessment, cardiac troponin and ECGs that we currently perform capture most cases of acute coronary syndromes presenting to the emergency departments, and they have a high sensitivity. The use of CTCA does reduce invasive angiography without affecting revascularization, suggesting avoidance of unnecessary invasive angiography and improvement of specificity. Clinicians and patients certainly seem to value the use of CTCA, despite no major impact on ultimate diagnosis, treatment or outcome, and CT coronary angiography may have an application where rapid access to invasive angiography is limited. There probably is a need to us look further into the data to establish whether or not there are potential subgroups who may well benefit from a CT coronary angiography, but that's work for us to do in the future. Thanks very much.